So we got some great questions from the audience, and I think we have a little bit of time to do questions. So one that was directed actually to San Bernardino, but I think others may have contributions to as well, is thinking about this issue that Terry raised in her presentation about a challenge being, do we have the capacity and the infrastructure in our community to provide quality treatment that'll work for this population? I think San Bernardino, you clearly, Kim, have a great example of actually Probation itself working with behavioral health to certify new drug Medi-Cal providers. But I was wondering, for all the counties, if you have thoughts about how to build out and strengthen the treatment capacity and infrastructure in our county so that we can actually meet the need that will result from all of this justice population enrollment into Medi-Cal.
Well, capacity is a problem across the entire healthcare system, not only in behavioral health and alcohol and drug, but also in primary care. And it's a particular problem in the safety net. So I can only speak to my county, but I know Mitch in LA, and I know it's the same problem there. And I can also say my wife is a primary care physician, and she was one of 5 doctors in a class of 160 that went into primary care. So we're just not training enough folks. So I was really excited to hear the San Bernardino model of just co-locating in the day reporting centers, nurse practitioners, and really what I would call the retail clinic model. So I think that there are new delivery models that we have to explore to increase capacity. We can't just build a clinic on every corner. So like the story I heard about San Bernardino, which I think is really forward-thinking and thoughtful, and this is happening in the private sector right now. Walgreens, CVS, Rite Aid, Kmart, Safeway, right? You can show up there and pay $40, get your prescription refilled, and buy candy all at once. That type of model where we bring new access points, low cost, to places where people are at, like a day reporting center, or like a school, or a community college, or even a fire station. I think you will see a lot of local jurisdictions piloting and experimenting with new access points for treatment that are low cost and in the current behavioral patterns of the clients we serve.
Kim, do you want to share a little bit about how you came to develop that model with behavioral health, and maybe even a little bit about, if you know, what the certification process was like for those clinics?
I would love to say I came to develop this model, but under the leadership of DBH, actually, Department of Behavioral Health, they were the lead in completing the California Department of Healthcare Services application for Medi-Cal certification. And then, of course, they gave us our direction. Things like making sure that there's available confidential meeting rooms for individual and group therapy, making sure that we're compliant with all of the appropriate postings throughout the day reporting center, making sure that we have available on site at all of the clinics areas where their files can be secured. They have to be in a locked cabinet in a locked area. So DBH would be able to speak more specifically to that, but it was actually the process that is available and explained on the Department of Healthcare Services website. But DBH completed that application. We were about 6 months out. I hope I'm giving the right time frame, Georgina and Becky, from the time that the application went in to being able to get our site visit for certification. So when I talk about some of the logistics, securing files, making sure we have adequate interview space, we went through those things in the process, and of course keeping us aware of the timeline. So that was basically our process under their leadership.
There's one thing that I wanted to say in my remarks that I forgot, which is you all could be billing Medicaid right now. For all of you who are employed and being paid with a public dollar, what we're doing right now is something called program planning and policy development. We're thinking about how to connect Medicaid beneficiaries to Medicaid-funded services. So that program is called Medicaid Administrative Activities. And remember how I said in 1965 Medicaid was created? And it paid for things like a doctor's visit or an ambulance. And it quickly became apparent that there was other things that were necessary for the full and complete administration of the Medicaid program. Eligibility, enrollment, outreach, program planning and policy development, transportation. These are the claimable categories under something called Medicaid administrative activities. And we did it in 2009 with juvenile probation in Alameda County for something called the Family Preservation Unit, which was, I think, was about 24 staff or so. We wrote what's called a MA claim plan, and we had the probation staff fill out every month how much time they spent doing each activity. And for that 24-person unit, we created $190,000 in new revenue. So we're working with Jenny and California's and a couple other, frankly, public safety partners to look at ways that we can leverage existing expenditures in public safety and help you claim Medicaid for work you're currently doing. Because if you're working in probation and being paid with a public dollar, and you're helping people connect to these services, you should be talking to your local public health authority because they control Medicaid administrative activities.
Just to add to your Medicaid administrative activities, you're eligible with your, it's called the federal financial participation, to claim up to 50% of the time for your staff that are performing those allowable activities. As you stated previously, the guidelines were a little bit more stringent, a little bit more difficult for probation departments, but under the guidelines, those have been changed and expanded. They're a little bit more flexible for probation departments, so I would imagine, like our county, some counties are coming out with new plans to capture those reimbursable activities. So to take a look at how that's being done would be probably very beneficial.
Great, thanks. Yeah, and I just want to mention or underline, I'm glad we brought up Medicaid-administered activities. This is actually also, in addition to being to bill for our attendance at the Realignment Conference, it can also help pay for application assistance and enrollment. For probationers, you know, throughout their time with probation or anyone residing in the community, you can bill for that, but you can also bill for enrollment of inmates in a county jail in the last 30 days of their stay. So for a pretrial inmate, you know, many people may only be in custody for a month or less, and so you could even assist someone with an application as part of the booking process and bill the MA program for that. So just wanted to underline that since we're talking about enrollment. Speaking of which, we got a question about strategies for enrolling jail inmates or other people in the justice system into health coverage. It can be tricky to fit benefits enrollment into the process design for probation or for a jail, and so I just, you know, we have some counties that already have some experience doing that, and I just wanted to see if anybody has any thoughts about what some of the challenges are and how you've met them.
Yeah, so for people like me, talking about health insurance is great, right? It's like an exciting topic. But how many people here love to run and go home and interact with their third-party insurer? It's like, great, I get to talk to Blue Cross tonight. Woo! So, first of all, as a culture, we've made it shameful to be tired, sick, or hurt. So, and remember, most of the folks we're dealing with are men. So, just to need care in and of itself, I think, is there's a gender issue there. The second is it's bureaucratic and demeaning. If you've never filled out a Medicaid application, just get one once and see what it's like. Just take a look at it. It's horrible. And third, we expect folks to, in their greatest time of need, go and interact with folks who don't know anything about them, with all due respect to us. The success to our efforts in Alameda County, where we have over 90% of the Medicaid population pre-enrolled, is what we call point of service enrollment. The clinicians and the therapeutic teams that have an alliance with the people they serve are the best eligibility technicians. Self-sufficiency centers don't work. Putting people in lines don't work. You got to find folks who have a connection or a real place in the lives of the folks we serve, and those are the people for whom you will have success in building a culture of coverage. So for us, again, we did point of service. We used a product called One app. We put it in 60 locations in every community clinic, in every emergency department, and when someone presented for care, we enrolled them. It's going to be hard to do this, so I don't want to pretend like it's going to be easy. But I think there are ways that public safety partners, particularly at the front end of the booking side, can pre-populate Medi-Cal applications and can, frankly, speed the process. Long term, we can't ever erase personal responsibility. First of all, it's the law. You got to have it. To be an American citizen, you have to have health insurance. But we can make it easier by co-locating treatment professionals in places where our people are and using them to connect folks to benefits and benefits enrollment.
Yes. That's funny. And that's Dr. Becky Gelke-Baez.
And in the jails, I mean, let's be honest. We did realignment. We know how to feed inmates. I'm pretty sure if we can figure out how to feed inmates, we can figure out how to partner between public health and custody to get benefit enrollment people in there. We do it now. Every jail system does do some benefit enrollment because you're releasing people from licensed environments that you have to get them placed into a licensed environment. So it's just a struggle, but you get it done. We'll get it done in LA.
For us at the day reporting centers, when people come in, ideally you want everybody to see the TAD worker who helps you get your application done. We also have computer labs on site. But the reality is, let's say I think Thursday, we had 97 people just coming in the door by 9:50 a.m. So the reality is you're not going to enroll all of those people into Affordable Care Act, AeroCare, or Medi-Cal. So what happens, some people get an appointment, but we also work with our probation officers, our mental health team, workforce development to identify another point of enrollment, whether we are on the phones, TAD, or whomever, making an appointment for them to report directly to that site or giving them an appointment to come back to our site. But ideally, you want to get everybody enrolled, but the sheer numbers do make it a challenge.
I got to make one quick just language note because we got to get the words right. It's something that's very poorly understood. In California, Medicaid is called Medi-Cal, right? Historically, Medi-Cal has been a fee-for-service program. You got a card that said Medi-Cal. But that was like having a ticket to nowhere because no one took those cards or rates. Beginning in the mid-1990s, the Medi-Cal program moved from a fee-for-service program to a managed care program. And it's continued at quite a pace. In fact, over the last year, not just mamas and babies, but now the SPDs, or what we call the seniors and people with disability, have all moved into managed care as well. And beginning in January in 8 counties, I'm not sure if LA is one of them, those who are dually eligible for Medicaid and Medicare will begin moving in. But the point I'm trying to make is most people in Medi-Cal will be in an insurance product that follows the same rules and laws, the Knox-Keene laws, that your private insurance company follows. In fact, many are going to be in Blue Cross. So for those of you who've had historic interactions with the Medi-Cal program in California, This fundamental change from fee-for-service to managed care has to be understood. That most of your clients will now be carrying around a managed care card, and they'll be members of a managed care plan. And that's different than what has been previously.
Thanks. Now, I have a question actually that's specific for San Bernardino, although if the rest of you have thoughts on this as well, that'd be welcomed. But we're interested to know how the Day Reporting Center tracks your outcomes and successes.
Every month, it's reported how many people are actually seen at the Day Reporting Center, how many people, of course, enroll in classes, successfully complete those classes. For transitional assistance, every month there's a report generated on how many people for the DRC as a point of entry are enrolled in, completed and enrolled in CalFresh through their application, also through any medical healthcare services. Those referred for general relief consideration or CalWorks is also tracked, and they attach in that same report the monetary amount or value of that. From DBH, every month we receive a report for the number of clients placed in alcohol and drug treatment beds, the number of clients placed in Department of Behavioral Health housing, and number of clients contacted is tracked through our mental health services unit. Workforce development also generates a report of the number of people referred for employment, employed, or those placed in hard skills employment programs that are expected to lead to employment.
Thank you. It looks like time is short, but I definitely want to just ask if anybody has any closing thoughts for the group on this topic.
It's going to be ugly and messy. Stuff's not going to work. It's an imperfect solution, and it's the most important thing to happen to my field in my lifetime. And all it is an opportunity. So I've been delighted and frankly pleasantly surprised by partners in public safety's willingness, energy, and commitment to making it happen. So for everyone here, thank you so much for your focus on this issue. Healthcare is a basic human right. We can administer it. It can be made to happen. And don't believe the hype. A lot of good stuff has already happened. Since March 2010, when the Affordable Care Act passed, the cost of healthcare has grown at the lowest level in the history of the American healthcare system. Over 2.6 million people have gotten coverage who wouldn't have had it before, and many, many, many millions of dollars have been saved through an expansion of primary care access. So it's not going to be pretty, but it will be incrementally better. And thank you for supporting us in doing it.